కొంచెం దగ్గర వేసేది పాప. Good morning, everybody. We have been talking about actually Ocular Therapeutics. And this is, I think, the last but one topic for you people in the syllabus. So the next thing may be actually the instruments which we ask you in the examination in the afternoon. So that I will be taking actually afterwards. After completion of this class, actually, you are supposed to give your seminar on conjunctivitis. The first three people, we get ready for tomorrow. Suppose if I complete it today, actually, you are going to present your seminar tomorrow morning. And Dr. Sahiti will be moderating the seminar, okay? So we have already seen that about the pharmacodynamics of the drugs used in ocular diseases. So it is nothing but actually the biological activity and clinical effect of the drug. And suppose if the drug is working at the receptor level, it can be an agonist or an antagonist. If the drug is working at the enzyme level, it can be an activator or inhibitor. And we have also seen actually the pharmacokinetics, it is the absorption, distribution, metabolism, and excretion of the drug from the body. And the drugs can be delivered to the ocular tissues by various means. One is eye drops and second one is eye ointment. And periocular injections such as subconjunctival injection, anti-septinon injection, post-septinon injection, and peribulbar injection, retrobulbar injection, all these things, and intraocular injections, intracameral and intravitreal. And systemically, it can be oral tablets or intravenous injections. Okay. Tear film also we have seen under the normal circumstances, the tear film will be around 5 to 7 microliters. With the normal rate of secretion is around 1 to 2 microliters per minute. When we add a drop, it increases actually blinking, squeezing of the drug or the liquid which is there in the conjunctival cul sac, which propels towards the sac. So the drug passes into the lacrimal sac, nasolacrimal system, and then bypassing the levoid goes into the systemic circulation. And the drug passes secondly into the iris and ciliary body, and from there to systemic circulation. Cornea, it is the lipid content of the epithelium and endothelium is 100 times more than that of the stroma, and therefore it allows actually lipophilic than hydrophilic substances. Because of the dual nature of corneal barriers, drugs possessing both lipid and water solubility, they penetrate actually the cornea more easily when compared to less soluble lipid drugs. Okay. Factors influencing local drug penetration into the ocular tissue depends upon drug concentration and solubility. The higher the concentration, the better is the penetration. But pilocarpine 1 to 4% actually it is a example. The 4% drugs actually the concentration will be more actually in the ocular tissues, but the action actually is limited by reflex blink tearing up because of the pilocarpine. Viscosity, the more the viscosity of the drug, the better is the penetration and increases the contact time with the ocular tissues, and it aids in drug penetration also. So to increase the viscosity of the drug, we add actually methacellulose or polyvinyl alcohol. Lipid solubility, the higher the lipid solubility and the more the penetration of the drug. Surfactants such as benzalkonium and thiomersal, these are the preservatives which are used in ocular preparations after cell membrane in the cornea and increases the drug permeability. And normal pH of the TRC is around 7.4. And if the drug pH is much different, this causes reflex tearing. Drug tonicity, when an alkaloid drug is put in a relatively alkaloid medium, the proportion of the unchanged form will increase, thus more penetration will occur. Ocular drug delivery. So we have eye drops. So each drop of any drug, actually ocular medication, contains about 50 microliters. So 1 ml contains approximately about 15 to 20 drops. Volume of the conjunctival cul-de-sac after drug instillation is around 7 to 10 microliters. Hence, only 20% of the drop instilled, it gets retained actually in the conjunctival cul-de-sac. The rest is actually thrown out. Topical medications are to be used, such as solutions and suspensions, and ointments. Ointments, they increase actually the contact time of the ocular medication with the ocular tissues, ocular surface, thus it will have actually better effect. But the disadvantage associated with this is vision burning, hence it can be used only in the night time. The drug has to be highly lipid soluble and to some extent water soluble to have the maximum effect of the ointment. Periocular injections, they bypass actually the conjunctival and the corneal epithelial cell layers. So these are subconjunctival injections, septinon, anti-septinon and post-septinon, and retrobulbar injections allow medications behind the lens iris diaphragm. They are useful for drugs with low lipid solubility. Higher the lipid solubility, higher the penetration, you know pretty well. So the drugs with low lipid solubility, they can be given in the periocular, in the form of periocular injections. Delivering medication closer to the local site of action, that is post-septinon injection, in case of posterior uveitis and posterior uveitis. Retrobulbar and peribulbar anesthesias, they are well-known procedures. So intraocular injections, intracameral or intravitreal. Intracameral, normally it is used during the surgery. After completion of actually any intraocular surgery, we may give actually an antibiotic such as moxifloxacin or any other antibiotic intracamerally into the anterior chamber. And suppose if while doing actually the intraocular surgery, if the pupil gets constricted, we give intracameral adrenaline for dilatation of the pupil and for completion of the intraocular surgery. In case if there is actually any PC rent and we are not able to place actually a posterior chamber IOL, in such cases we inject intracameral pilocarpine or ecothyroid so that there will be meiosis and we can place actually the IOL and the anterior chamber. Okay, intravitreal in diabetic edema. Suppose intravitreal steroids, it can be given in diabetic edema, and we can give actually Avastin or we can give as Lucentin. All these things actually anti-VEGF substitutes for central retinal vein occlusion, and also in retinal surgeries we have some other ocular medications which we inject. Intraocular implants, ganciclovir for CMV retinitis, Retisert, a fluocinolone, this thing which we use actually in case of posterior uveitis. Systemic drugs, so either they can be oral or intravenous, and factors influencing actually systemic drug penetration into the ocular tissues. One is its lipid solubility of the drug, more penetration with higher lipid solubility, and protein binding. So lesser the protein binding, low protein binding, and more effect will be there, and better penetration in case of inflamed eyes. Methods of ocular drug design, I don't think it's needed for you people, it's for postgraduates, we'll skip it. So we have some 4 types of actually the ocular medication which are useful for you in the point of examination. One is anti-inflammatory drugs, mydriatics and cycloplegics, and anti-glaucoma and lubricants. Anti-inflammatory drugs, they are again corticosteroids, NSAIDs, immunosuppressives, and mast cell stabilizers. So corticosteroids, they are useful in control of inflammation and also in immunological diseases of the eye. So the routes of administration of corticosteroids, either it can be topical or periocular, intravitreal, oral, or intravenous. So their anti-inflammatory and immunosuppressive action is because of its inhibition of lymphocytes proliferation with a decrease of the cell-mediated immunity, inhibition of degranulation of neutrophil granulates, macrophages, mast cells, and also basophil granulates. And also it decreases the vascular permeability and decreases the prostaglandin production. So that's how actually the anti-corticosteroids they act. This also is not needed. So if you see, actually there are various innumerable indications for usage of steroids, whatever may be the mode of administration, be topical, or intravitreal, intracameral, whatever it is. Okay. So the various indications we have are, one is the first and foremost is post-surgical inflammation. We give it actually in almost all surgical cases, at least for about 3 to 4 weeks. Allergic conjunctivitis and blepharitis can, and next we have vernal conjunctivitis. Initially, we start all the patella conjunctivitis, we start them actually with steroids. This form and interstitial keratitis is another thing. Suppose if there is a resection of corneal graft after kertoplasty, we use actually steroids. And scleritis and episcleritis be of whatever etiology it is, and anterior and posterior uveitis, whatever be the etiology, we start them on and steroids, local steroids, and sometimes systemic steroids or immunosuppressants. And traumatic inflammation of the eye, supposing the eye is actually inflamed because of the trauma. So is traumatic conjunctivitis or all these things, actually we can use steroids. A papillitis or retrobulbar neuritis, the drug of choice is always a steroid. And sympathetic ophthalmia, so in case of perforating injuries of the eye, suppose if the other eye actually gets sympathetic ophthalmitis, so we start them on steroids, and that reduces actually the disease in the sympathizing eye. Herpes zoster ophthalmicus, in case of keratitis, we can as well use steroids. And herpes orbital pseudotumors. So to reduce the volume of the tumor, we use actually steroids. Okay. So there are certain contraindications for usage of steroids. So the topical contraindications are acute viral infections, herpes simplex, and fungal diseases, fungal corneal ulcer, and ocular tuberculosis, and acute conjunctivitis. Caution in pregnancy and lactation. So in pregnancy and lactation, normally we try to avoid steroid administration. And systemic contraindications are stands for psychosis, headaches, and pseudotumor cerebri, and T for thrombosis, venous thrombosis, central retinal vein thrombosis, or transretinal vein thrombosis, and E, endocrinal, suppressed hypothalamic pituitary adrenal axis, and retarded growth of the individual, and Cushing-Guy state of the person. Suppose if it is there, actually we try to avoid it. And retention of fluid and sodium, but loss of potassium and systemic alkalosis. This is also actually a contraindication for usage of steroids. Suppose if the patient is of postmenopausal this thing and having osteoporosis already, and if there are any evidence of myopathies, we don't use it. And in case of immunosuppression with secondary infections, especially tuberculosis and fungal, so we don't use systemic steroids. And in case of diabetes, hypertension, duodenal ulcer, and also gastric ulcers, so these people, these things actually they get flared up in case we use steroids in their presence. Okay. So the side effects of steroids are, the topical side effects are the patient may get glaucoma, a posterior subcapsular cataract, a dry eye, reduced resistance to bacterial and fungal and viral infections, and secondary infections can also occur, and a scleral melting can occur, and delayed wound healing can occur, and eyelid skin atrophy can also occur as a topical side effect of the corticosteroids. Systemic drugs, systemic steroids, when we administrate, so there will be an ocular side effects and suppression of hypothalamic pituitary adrenal axis, and hyperglycemia can also occur, especially in diabetics. And suppose if the patient swallows it on an empty stomach, and if he continues to do it for a long period, there is incidence of actually peptic ulcer in these people. Osteoporosis is precipitated. Psychiatric disturbances are seen in these people. Cushing's habitus, the people, they become very bulky, and the Cushing habitus is seen. And fetal abnormalities, suppose if it is given to the pregnant women, can also occur. And these people, they are susceptible for secondary infections. So these are the side effects, systemic side effects of the corticosteroids. So the various topical corticosteroids which we use in ophthalmology are They are available both as solution, suspensions, and also ointments. Hydrocortisone 0.5 to 1.5%, prednisolone 0.1 to 0.251%, dexamethasone 0.1%, betamethasone 0.1%, and triamcinolone 0.1%, fluorometholone 0.1%, loteprednol 0.2 to 0.5%, difluprednate 0.005%. So anti-inflammatory action of prednisolone estate is greater than fluorometholone estate, is greater than dexamethasone estate, and then betamethasone. So it's order of descending order. Prednisolone is the maximum anti-inflammatory action will have, and but prednisolone estate the permeability is less when compared to the dexamethasone. Okay. So rise of IOP, the intraocular pressure after the usage of the steroids, maximum rise is due to dexamethasone, and fluorometholone actually 0.1%. It has got very little. It's the least effect on rise in IOP. So loteprednol 0.2% is a soft steroid. It has got a very minimal effect on the rise in intraocular pressure and also systemic side effects. It's approved actually for allergic conjunctivitis combined with tobramycin 0.3% for superficial bacterial infections with inflammation. Triamcinolone 40 milligrams per kilogram per ml. The brand name is Kenacort. It was approved by FDA in 2007 for intraocular injections in visualization during the vitrectomy. Suppose when we do a vitrectomy, the vitreous will be very hazy. So to have actually clear view, so sometimes we may inject a triamcinolone. And the chronic non-infectious uveitis and also diabetic macular edema, we give intravitreal triamcinolone Kenacort, and it was approved by FDA. Reticet, fluocinolone acetonide, used in intraocular inflammation for chronic uveitis. So recent advances, we have difluprednate, diflupor, and diflupred. It's a prednisolone derivative in emulsion form, exhibits enhanced strong efficacy and low side effects. Indicated in post-operative inflammations and also in case of uveitis. QID dose is required. Ozurdex Allergan, actually, it is a manufacturer, dexamethasone intravitreal implants. So 0.7 milligrams. It's indicated in macular edema following retinal vein occlusion and non-infectious posterior uveitis also we give it. So oral corticosteroids, there are short-acting, intermediate-acting, and long-acting. Short-acting are hydrocortisone, cortisone, and prednisolone. Hydrocortisone, we give 20 milligrams per day. Rapid-acting medullary activity is there. And cortisone, actually 20 to 100 milligrams per day. And prednisolone, 1 to 2 milligrams per kilogram per day. And it is 4 times, prednisolone actually is 4 times more potent than the hydrocortisone. The intermediate acting oral corticosteroids are methylprednisolone 4 to 32 milligrams per day, and is selective than prednisolone. Triamcinolone 4 to 32 milligrams per day. Only glucocorticoid action is there. And long acting are dexamethasone and betamethasone. And dexamethasone 0.5 to 5 milligrams per day, and betamethasone 0.5 to 5 milligrams per day. They are highly selective glucocorticoids, and marked pituitary axis suppression is noted with these two drugs. Oral prednisolone in a dosage of 1 to 2 milligrams per kilogram per day or on alternate days is used to treat orbital inflammations such as orbital cellulitis, panophthalmitis, panuveitis, postoperative inflammations, and systemic diseases causing ocular problems. Alternate day therapy reduces the suppression of adrenal functions. High dose of methylprednisolone intravenous are given in pulses to treat optic neuropathy, neuritis, or retrovalvular neuritis. Deflazocort, recent glucocorticoid, a derivative of prednisolone with less complications. Sometimes it is used even in diabetics. And 6 milligrams of deflazocort is equivalent to 5 milligrams of prednisolone. Non-steroidal anti-inflammatory drugs, they are another thing actually which are commonly used in ophthalmic practice. they have three types of effects. First and foremost is anti-inflammatory effect, and second one is analgesic effect, and third one is antipyretic effect, COX-2 non-steroidal anti-inflammatory drugs. So it inhibits cyclooxygenase pathway. So oral NSAIDs, we have non-selective COX inhibitors, propionic acid derivatives, ibuprofen 400 milligrams per day can be given. It's a potent analgesic. And aryl acetic acid derivative, diclofenac and aceclofenac, 50 milligrams to 100 milligrams TID can be given. It has got analgesic, antipyretic, and anti-inflammatory effects. COX-2 inhibitors, nimesulide, nowadays actually we are not using it because it is banned in US and also in our parts. 100 milligrams BD, it can be given. Analgesics and antipyretic action is there. Poor anti-inflammatory action, para-aminophenol or paracetamol. So it can be taken in 300 to 650 milligrams. It has got an antipyretic effect. Ocular indications for use of NSAIDs. So we wish whenever we do an intraocular surgery that the pupil is persistently dilated and till the end of the surgery. Suppose if there is an intraoperative miosis, it becomes very difficult. That is the reason we use NSAIDs prior to the surgery, or 2 to 3 days prior to the surgery, or on the day of surgery also we use it. And it reduces post-operative inflammation. Suppose if the steroids are contraindicated, in such conditions actually we use NSAIDs to reduce the post-operative inflammation. Prevention and treatment of cystoid macular edema, especially in the post-operative, late post-operative complications of cystoid macular edema, it is more common in diabetics. So as to prevent as a prophylaxis, we give NSAIDs prior to the surgery. Okay. Non-infectious uveitis, so we can as well give NSAIDs. Scleritis and episcleritis, NSAIDs can be given. Allergic and giant papillary conjunctivitis also we give NSAIDs. So there are the various NSAIDs we have are flurbiprofen, ketorolac, and diclofenac. The various salient features, indications, and doses and side effects are for flurbiprofen. The solution is 0.03% solution. It causes, indications are inhibition of intraoperative meiosis. 1 drop every 30 minutes, 2 hours preoperatively. Total of 4 drops can be given. Transient burning and stinging sensation may cause actually increased bleeding tendency of the ocular tissues during the surgery. And second one is ketorolac, 0.5% solution. It has got analgesic and anti-inflammatory action. Ocular itching due to seasonal allergic conjunctivitis and foreign body sensation photophobia. These are the indications, and it should be given in TDS doses. And diclofenac, 0.1% solution, potent NSAID with analgesia. It's iatrogenic inflammation and post-cataract surgery pain. We can as well use it. The dosage is actually QID. And both these things, ketorolac and diclofenac, they have transient burning and stinging sensation, and they decrease actually the corneal sensitivity. Newer drugs, we have nepefenac. So nepefenac, 0.1%, bromefenac, 0.09% are topical non-steroidal anti-inflammatory agents which are recently introduced into the armamentarium. So nepefenac is a prodrug. It gets converted into ocular tissue hydrolysis to amphenac, which inhibits the action of prostaglandin H synthase, cyclooxygenase. Patients treated with these drugs were less likely to have ocular pain and measurable signs of inflammation, cells, flares in the anterior chamber and also in the vitreous in the early postoperative period as compared to ketorolac. Mast cell stabilizers and antihistaminics. Human eye has about 50 million mast cells, which contain performed clinical mediators. Allergic conjunctivitis, IgE-mediated hypersensitivity reaction. Mast cells and basophils, they produce actually histamine, leukotrienes, and chemotactic factors. which cause the histamine actually causes capillary dilatation, stimulation of nerve endings. Capillary dilatation increases permeability and stimulates the nerve endings. It causes pain and itching. And the capillary dilatation, it causes actually conjunctival injection and swelling. And so the various drugs we have are mast cell inhibitors, chromoline sodium. It inhibits neutrophils, eosinophil, and monocytes. And it is available actually in the concentration of 0.1%, not 1%, and it should be given twice per day. And it does not provide immediate relief. So corticosteroids normally initially started, and later on we continue it on mast cell inhibitors. H1 antagonists plus mast cell inhibitors such as elastin hydrochloride, epinastin hydrochloride, ketotifen fumarate, and metochromyl sodium, olopatadine. All these things they come under this group, and they provide immediate relief and prevent further degranulation. Rapid onset of action is there, and it's available in the doses of 0.05%. And ocular burning, stinging, and dry eyes, they are actually secondary side effects. H1 antagonists and decongestants, nefazorin, hydrochloride, phenyramine maleate, short-term relief for mild allergy, 0.05% to 0.1% VD solution. 0.1% solution is available. It is given twice a day. Immunosuppressive drugs not used as a primary therapy. Suppose there are other things that are not efficacious. In such conditions, in recalcitrant cases, we may resort to actually immunosuppressive therapy. They are not used, the cases not responding to steroids and steroid responders, where there is a chance of actually increase in blood pressure as a side effect, are started. They are the people who are having steroid complications. These people, they are kept on immunosuppressants. It should be avoided in children and pregnant women, and the effect takes about 1 to 4 weeks to develop. Hence, initial therapy with corticosteroids is a must. Azathioprine, cyclosporine, methotrexate are commonly being used. So the drug methotrexate, actually, it is available as 2.5, 5, and 7.5 milligrams. Dosage is weekly, and the adverse side effects are gastrointestinal symptoms and hepatotoxic. LFTs must be monitored while using actually methotrexate, and the cost is less and it's well tolerated. Azathioprine is available in 25 to 50 milligrams, and the dosage is 1 milligram per kilogram body weight. The adverse effects are myelosuppression, and onset takes about 4 to 5 weeks. And cyclosporine is a commonly used drug, and 25 to 50 milligrams, and also it's available in 0.95% to 0.1% emulsion. 5 milligrams per kilogram body weight per day is given. It is nephrotoxic, hence the monitoring urea and creatinine is a must. Fast onset of action, more efficacious, and dry eye can occur. Mycophenolate or mofetil, it's a 250 to 500 milligram are available. 1 gram BD is the dosage. Myelosuppression is a adverse effect, and the cost is exorbitant, prohibitive. Leflunomide in 10 to 20 milligrams are available, and 100 milligrams per day is the dosage. Gastrointestinal effect, upset, and hepatotoxicity is seen. It's still under trial. Mydriatics and cycloplegics, these are other things actually which we commonly use in ophthalmology. Mydriatics are nothing but they are the drugs which dilate the pupil, and cycloplegics are the agents which cause paralysis of the ciliary muscle. So mydriatics, they are either adrenergic agonists or cholinergic antagonists. Adrenergic agonists are adrenaline and phenylephrine, and cholinergic antagonists are tropicamide. So phenylephrine, it is available in 2.5% solution, 5% solution, 10% solution. Most common symptomatic agents used in this way are usually in ophthalmology. It acts on alpha-1 receptors for the dilator pupillae. The indications are for the pupillary dilatation, for refraction in the individuals above 40-50 years, where cycloplegia is not needed, And also before intraocular surgeries also we just instill this stuff for dilatation of the pupil. Contraindications, hypersensitivity, phenylephrine, and also in case of angle closure glaucoma, narrow angle glaucoma, and in patients who have cardiac problem, and in elderly individuals also we try to avoid actually phenylephrine. So the side effects are initial stinging and burning sensation will be there, and the systemic side effects of phenylephrine are they can be actually palpitation, tachycardia, headache, and arrhythmias. So reflex bradycardia, pulmonary embolism, and myocardial infarction, they are also reported as side effects of the phenylephrine. Adrenaline, it acts on dilator fibers and directly produces dilatation after installation of 4 drops, 1 in 1,00,000 solution. So may be combined with procaine or atropine to achieve mydriasis and severe iritis. Cycloplegic mydriatics is a parasympatholytic agents are commonly used. It blocks the action of cholinergic stimulation, causing paralysis of the accommodation and pupillary dilatation. And the indications are refraction in the individuals less than 40 years, and inflammation of the uvea, anti-uveitis, and also in case of malignant glaucoma, we give actually atropine. Adverse reactions, transient stinging and burning sensation. So it may increase actually intraocular pressure in the people who are prone for actually an angle closure. Allergic lid reactions and hyperemia, all these things can occur. Flushing and dryness of the skin, blurred vision, dryness of the mouth and nose, anhidrosis, fever, bladder distension, and CNS disturbances, all these things can occur as the complications or adverse effects of the cycloplegic drugs. So the precautions are permanent mydriasis may occur in patients with keratoconus. Longer acting agents may cause posterior synechial formation when treating anti-segment inflammation. That also we should keep it in mind. And it should be avoided. You should avoid driving or any other task requiring alertness after the usage of these drugs. Overdoses, administer parenteral physostigmine. It's commonly used agents are, we have atropine sulfate, hometropine, cyclopentylate, and propicamide. So atropine, it is available as 1% solution and also ointment. Installation regime is a rice grain size ointment is kept in the lower conjunctival cul-de-sac thrice per day for 3 days. And refraction actually, retinoscopy is done on the 4th day morning. Onset of action is 18 hours after the last installation. Recovery will occur in 10 to 14 days, sometimes 21 days. And indications are refraction retinoscopy in children less than 7 years. Strongest cycloplegic we have in ophthalmic armamentarium. And other uses are drug of choice in anti-segment inflammation, and penalization in amblyopia, and also in malignant glaucoma. We use it. Side effects, dose-related side effects are there. And in children, actually, atropine can cause a pyrexia, especially in the summer. In the summer, hyperpyrexia can occur, especially in the summer. So hometropine is available as 2% solution. 6 to 8 drops, 10 minutes apart should be installed. 40 minutes after the second drop, actually, the onset of action occurs. The recovery from the cycloplegia is in about 3 days. Acts more quickly and shorter action every early recovery. We can use it actually in low-grade uveitis. So tropicamide, 0.5% and 1% solution is there. 2 drops, 5 minutes apart. 20 minutes after the second drop, actually, the onset of action will occur. And the duration of action is for about 4 to 6 hours, and recovery occurs later. And the diagnostic procedures, refraction in elderly individuals or in any individual who requires mild cycloplegia can also be installed for refraction. And fundus examination, we can as well do it with actual tropicamide. And pre and post-operatively provocative tests, and also provocative tests for glaucoma. So angle closure, if you want to look, tropicamide is a short-acting one, and you can as well use it. 2 drops cyclopentylate, 2 drops 5 minutes apart, 30 minutes After the second drop can be the onset of action occurs. Recovery is in about 2 days, 48 to 72 hours. Short acting and most commonly used in post-cataract surgery. So atropine is the class down. Atropine is the most effective and strong cycloplegic, followed by cyclopentolate 1%, and then hometropine, and finally tropicamide 0.5 to 1%. Actually, there is a weak cycloplegic. Cyclopentolate should not be used in uveitis as it has chemotactic effect on leukocytes. Mydriasis is quickest with the tropicamide as the action is faster, and among all parasymptomatics, in about 20 minutes actually it occurs, and is also shortest lasting drug. So normally in 4 to 6 hours actually the eye return back to normal. 2.5% phenylephrine selective alpha-1 agonist along with anticholinergics like tropicamide 0.8% induces maximum mydriasis. So we have in combinations. So topical hyperosmotic agents, these agents are helpful in treating corneal edema of diverse etiology. Epithelial edema is more responsive as compared to the stromal edema. Osmotic gradient is created between epithelium and tear film by these agents. Water is then drawn towards the more osmotic compartment and is then eliminated from the epithelium and stroma. Commercially available are topical sodium chloride solution, 2% or 5%, topical sodium chloride ointment, 6%, gel is available. Dosage is 5 to 6 times a day for drops and 2 to 3 times a day for gels till the desired response of corneal edema, stromal or epithelial edema has come down. Gel form is more superior in terms of efficacy and also tolerability. Ocular lubricants, they are available as drops, gels, and ointments. The indication is protection and lubrication of the cornea and also the surrounding structures. And it is actually used in exposure keratitis, lid retraction, or Bell's palsy, whatever it is. Decreased corneal sensitivity in case of leprosy, and recurrent corneal erosions. So all these cases actually we use the ocular lubricants. So the important artificial tear components are demulcents, preservatives, and buffer. So demulcents, they are hydrogels, and hydrogels are the viscosity enhancing active ingredients of the artificial tear. And preservatives, they reduce actually the risk of bacterial contamination in multi-dose containers and to a prolonged shelf life. Example, we have preservatives, benzalkonium hydrochloride, oxychlorocomplex. These two things, they are available. And adverse effects of tear substitutes are sometimes where the patient may experience actually redness, stinging, and temporary blurring of the vision, hypersensitivity reactions connected. Various tear substitutes available can be categorized as cellulose derivatives and polyvinyl polymers, carboxymethyl cellulose, carboxyethyl cellulose, carboxypropyl cellulose, and hydroxypropyl methyl cellulose. And polyvinyl polymers are polyvinyl alcohol, polyvinyl pyrrolidine, and polymethylene, polyethylene glycol. So cellular derivatives and polyvinyl alcohol based, those are the two things. Polysaccharides and synthetic polymers. For cellular derivatives, they mix well with the ophthalmic products. Only benefit is aqueous deficiency, and hyperomellose can cause actually crusting of lids mimicking blepharitis, and they are available actually in 0.5% and 1% solution. And blurring of the vision is common with these cellular derivatives. And polyvinyl alcohol based synthetic polymers, they do not mix actually with the other ophthalmic products. Beneficial is in lipid, aqueous, and mucin layer deficiencies in case of dry eyes, and short retention time on ocular surface. 1% and 1.4% solutions, they are available. They're water soluble and does not dry the vision. Ointments, major advantage is that ointment has got a prolonged action, retain longer action than the solutions. They are available as petrolatum, lanolin, mineral oil, topical ointments. The dosage is bedtime actually it's preferred because daytime it has blurring, and solution should be instilled prior to the application of the ointment. Recent advances, carbopol 980 polyacrylic acid containing gel is developed which minimizes blurring and also less dose is required in these cases. Anti-glaucoma drugs, this is another thing actually which we ask in the examination, we keep timolol maleate or some other thing. So we have beta blockers, alpha agonists, prostaglandin analogs, and carbonic anhydrase inhibitors and fluorocholinergic drugs. So beta blockers again they are non-selective and selective. Non-selective are timolol maleate, levobunolol, metoprolol, and carpiolol. And selective beta blockers are betaxolol. And alpha agonists, sympathomimetic drugs, brimonidine 0.2%, alpha apracolanidine 0.5% to 1%, and dipivefrin 0.1%, epinephrine 1 to 2%. And prostaglandin analogs, we have latanoprost 0.005%, bimetoprost 0.03%, travoprost 0.004%, minoprostone 0.15%, and carbonic anhydrase inhibitors, dorzolamide or brinzolamide, we have dorzolamide 2% solution and brinzolamide 1% solution. Cholinergic, parasympathomimetic drugs, pilocarpine and carbachol, we have. Cholinergic agents, drugs either act directly by stimulating the cholinergic receptors or indirectly by inhibiting the enzyme cholinesterase. And topically applied cholinergic agents, they cause contraction of iris sphincter, thereby resulting in actually a meiosis. And circular muscle of ciliary body and relaxing paralysis of circular muscle of ciliary body, relaxing of jonular tension, relaxing the jonular tension, and forward movement of lens iris diaphragm. It causes actually accommodation. Longitudinal muscle of ciliary body, tension and scleral spur, open up trabecular meshwork, and aqueous flow is increased. Side effects of cholinergic agents, so the lids, orbicular muscle spasm and twitching can occur, and conjunctival irritation and conjunctival hyperemia and allergic conjunctivitis can occur. Cornea, epithelial staining and vascularization, atypical band keratopathy can also occur. Iris, there will be hyperemia, pigment epithelial cyst formation, post-operative iritis, and synechia formation can also occur. A lens, a cataract can occur, increase lens thickness, and the patient may have a myopia. Systemic sweating, salivation, lacrimation, nausea, vomiting, and abdominal cramps, nightmare, bronchial spasms, asthma, and pulmonary edema. All these complications, they may or they may not occur. Depends upon the individual and their predisposition for it. Pilocarpine is the oldest and most widely used cholinergic agent, derived from the plant Pilocarpus microphyllus. So it's available as topical solution in 2 salts, pilocarpine hydrochloride in the strengths of 0.25, 0.5, 1, 2, 3, 4%. Pilocarpine nitrate in strengths of 1%, 2%, and 4%. It produces a reduction of IOP that starts about 1 hour after the installation and lasts for about 4 to 8 hours or 6 to 8 hours. The IOP decrease after the use of actually pilocarpine is around 15 to 20% from the basal IOP. So in open angle glaucoma, it causes opening of the trabecular pores, increases the drainage, and contraction of longitudinal fibers of the ciliary muscles and inserted into the scleral spur. Okay, and in angle closure glaucoma, it decreases the volume of iris in the pupillary, in the periphery, away from the trabecular meshwork or tissue, and peripheral iris is pulled away from the trabecular meshwork because of the meiosis caused. So that's how actually it acts, pilocarpine. Indications for pilocarpine, it is first line for acute and chronic angular closure glaucoma, primary open angle glaucoma. Previously, we used it, and nowadays there are better drugs that we are not using pilocarpine, unless certain indications are neovascular glaucoma, uveitis, and related glaucomas. Also, it's used in laser trabeculoplasty, accommodative esotropia. Diagnostically, in adystonic pupil, we use it. Carbachol, it is a synthetic derivative of choline, long-acting than pilocarpine, indications intracameral 0.1% used during the anti-segment surgery for constricting the pupil. It can be used actually in patients who are allergic to pilocarpine. So beta blockers, usually first line agent for treating most types of glaucoma nowadays. Excellent IOP lowering efficacy is there, and the duration of action is very long and few ocular side effects. So first commercially available beta blocker for systemic use was propranolol, and for topical use it is timolol maleate. It reduces IOP by about 20 to 30% of the basal level, with little or no effect on the pupillary size or accommodation. Blurred vision associated with miotics is not seen actually with the beta blockers. And mechanism of action is it decreases aqueous humor production by inhibiting catecholamine stimulated synthesis of CAMP. Effective in glaucomatous non-motensive eyes, indicated in primary and secondary open angle glaucoma, secondary angle closure glaucoma after penetrating keratoplasty, aphakic and pseudophakic glaucoma, acute and chronic primary angle closure glaucoma, and development glaucoma. So systemic side effects and contraindications for beta blockers are side effects are burning sensation, hyperemia, superficial punctate keratitis, corneal anesthesia, allergic blepharoconjunctivitis, dry eye, bronchospasm, masking of hypoglycemia in case of diabetics, heart failure and pulmonary edema, AV dissociation, and cardiac arrest in patients with pre-existing partial heart blocks. And the contraindications are it should not be used in case of bronchial asthma, COPD, sinus bradycardia, second and third degree AV block, and sexual dysfunction. So beta blockers, non-selective and selective. Non-selective beta blockers are timolol, levobinolol, and cartilol, where selective beta blockers are betaxolol. Timolol maleate, first beta blocker to be commercially available in 1978. It is non-selective, inhibits both beta-1 and beta-2 receptors. And peak level of the drug is seen in about 1 to 2 hours. Clinically effect may last for about 2 weeks after the last use. Availability is in 0.25% solution, 0.5% solution, 0.5%. Normally we use 0.5% solution. Administered in a BD dosage. Also available in gel solution, hence can be administered once daily. Short-term escape due to receptor alteration can be there. Long-term drift due to tachyphylaxis is also seen, and contraindicated actually in asthmatics, heart failure patients, and COPD patients. Betaxolol, it's a cardioselective beta-1 blocker, safely used in asthmatic and cardiac patients. 0.25 to 0.5% in BD doses can be administered. IOP lowering effect is about 26%. Response may require few weeks to stabilize. Optipress is the trade name of betaxolol. We have cartilol, non-selective beta-1, beta-2 blocker. It has fewer side effects, better for cardiovascular patients. 1 to 2% BD dosage is there. IOP lowering effect is around 32%. Ocupress, 1% actually is the trade name. Levobinolol, non-selective beta-1, beta-2 blockers. The long-term drift is less than timolol, 0.25 to 0.5% solution is there. IOP lowering effect is around 30%, used in OD doses, has longer life, half-life. Beta-gon is 0.5% solution. Alpha-adrenergic agonists, directly acting symptomimetics, epinephrine, dipinephrine, alpha-2 adrenergic agonists, apracolonidine and brimonidine, indicated in open-angle glaucoma to control IOP spikes after laser procedures, and ocular hypertension. These things are used. Brimonidine recently introduced second-generation alpha-adrenergic receptor agonist with high degree of selective to alpha-2 receptors. It increases both aqueous production like beta blockers, and also increases uveoscleral outflow like prostaglandins. It has got binding sites in the iris epithelium, ciliary muscle, retina, and retinal epithelium, and choroid. IOP reduction with the usage is around 26% in 2 hours post-dose and has an additive neuroprotective action. It's available as 0.25%, 0.2% solution, 0.5% solution, 0.1% solution, 5, 10 ml, 15 ml packs are there. Instill 1 drop 2 to 3 times per day. Side effects include actually the ocular allergy, follicular conjunctivitis, lid edema, dry mouth, and headache. And contraindications in patients receiving MAO inhibitor therapy, tricyclic antidepressants, produces cardiovascular instability in infants and is therefore contraindicated in children less than 5 years. Brimonidine is effective. Effectiveness may be reduced by concomitant administration of NSAIDs. Carbonic anhydrase inhibitors, it inhibits enzyme carbonic anhydrase present in pigmented and non-pigmented epithelium of ciliary body, prevents the bicarbonate and sodium influx and decreases the aqueous formation. It is useful in short-term treatment of acute glaucoma. Onset of action is within 1 hour and maximum effect is seen about 4 to 6 hours. Topical carbonic anhydrase inhibitors are dorzolamide and brinzolamide. Local inhibition of carbonic anhydrase in the ciliary body minimizes side effects. Adverse effects including burning, stinging, blurred cell vision, systemic side effects is rare, and caution must be exercised in patients with compromised epithelium. So dorzolamide is available in as 2% solution, and the dosage is TDS and has better penetration, Dorzox and TrueSoft. These are the trade names. And 1% solution, brinzolamide, and safe and well tolerated. Azopt is the so the prostaglandins. The prostaglandin derivatives primarily lower the IOP by enhancing the uveoscleral outflow. Two possible mechanisms exist that has been studied and are relaxation of the ciliary muscle and remodeling of the extracellular matrix of the ciliary muscle. And first line for the open angle glaucoma, ocular hypertension, exfoliation, and pigmented glaucoma. Less certain indications are angle closure and neovascular glaucomas, contraindicated in erratic patients, pregnancy, and uveitic glaucomas. So latanoprost, travoprost, and bimatoprost, these are the things. They increase actually uveoscleral outflow. Bimatoprost actually decreases resistance to the outflow. Duration of action is around 12 to 24 hours. Washout period is about 3 to 4 weeks. Burning, stinging, conjunctival hyperemia, iris pigmentation, anti-uveitis, hypertrichosis of the eyelashes are all seen actually as side effects. Latanoprost is available as 0.005% OD dosage. Travoprost is 0.004% OD dosage, and brimatoprost as 0.03% OD dosage. And safest and most efficacious latanoprost, best in maintenance and diurnal variation of IOP and stable in case of bimatoprost and travoprost, and bimatoprost actually controls the diurnal variation better than latanoprost. Contraindicated with pilocarpine, latanoprost, stable and safe and well tolerable, and highest incidence red eye rate. Zelantan, 9 PM, these are the drugs of latanoprost trade names, and Travatan is travoprost, and Lumigan and Careprost are bimatoprost. So fixed combinations we have, the advantages are convenience, compliance, and effectiveness, and cost effectiveness, and safety and tolerability. And disadvantages are not always as additive as expected. Best scientific combinations are one drug from one group, that is, which reduces aqueous formation and which increases aqueous uveoscleral outflow. Few combinations are timolol, brimonidine, timolol and dorzolamide, and brimonidine and timolol, latanoprost and timolol, travoprost and timolol, and bimatoprost and timolol. Systemic anti-glaucoma medications, eskezolamide, glycerine, mannitol. Neuroprotective drugs are calcium channel blockers, nitric oxide synthase inhibitors, vasodilators, and antioxidants. Nitazolamide is commonly used. It's an oral carbonic anhydrase inhibitor. Tablets are 125 to 250 milligrams are available. Onset of action is within 1 hour. Peak action is at 4 hours. Duration of action is 8 to 12 hours. Slow release capsule, intravenous 500 milligram vials are there, useful in acute glaucoma, cystoid macular edema, altitude sickness, altitude thickness, epilepsy, and respiratory summit. Adverse side effects are intolerance to the adverse effects, commonly in elderly people, and neurological and psychiatric disorders, gastrointestinal upset, we don't use it, and renal, increased maturation frequency, renal stones and hypercalcemia, and hematological bone marrow suppression, plastic anemia, tetogenic effect, contraindicated. Hyperosmotic agents, increases osmolarity. Oral glycerol is one, mannitol is commonly used, 20% solution. We give it as in about 30 minutes. Peak of action is 30 minutes and duration of action is 6 hours. Neuroprotective drugs, normally we don't ask you in the examination, it's for postgraduates. And that ends actually, I think I went a little faster, but I will have to complete it today. So this is actually regarding the ocular therapeutics and the drugs we use in ocular diseases as an armament for treating various diseases of the eye. And thank you. Tomorrow, I repeat, tomorrow you are going to have actually a seminar on conjunctiva. Okay, the first 3 people in the list. Actually, you get prepared, and Dr. Sahiti will be your moderator. Same time tomorrow.